Thank you, Stephen, and welcome everybody. Many of our patients, when we see, maybe the percentage of patients statistics might vary according to the disease, but majority of palliative care physicians see patients with cancer, and many of you might have more of cancer patients. That's the importance of this session. Today we are going to talk about the basics of radiation oncology and medical oncology. So these are some things which we should know when we see patients with cancer, so that we can actually manage the patient as well as refer the patient whenever needed. The radiation oncology, the class will be done by Dr. Manu John, who has done his DMRT, and he has done his courses in palliative care, 6-week certificate course in palliative care, as well as 1-year fellowship, national fellowship in palliative medicine from Institute of Palliative Medicine at Calicut. And presently, he is working as the head of the Department of Palliative Oncology at Caritas Hospital. He is also an external expert in research committee of Caritas College of Nursing, as well as member secretary in ethics committee of Caritas Hospital. He is also the executive member of Kottayam District Consortium of Palliative Care Organization. He actually won a few awards, Caritas Doctors Excellence Award in 2018 as well as in 2022, then Recognition Award by Kottayam Brahman Sabha in 2017 and by Shraddha Home Care Services. He's an active member, even though he's an oncologist. I have been seeing him in palliative care conferences. Dr. Manu, welcome you to this session.
Thank you, sir.
The next person to be introduced is Dr. Suneesh. So Dr. Suneesh presently working as the assistant professor in the Division of Medical and Hemato-Oncology at MSc Medical College Hospital, Kolanjeri. He did his MBBS from Government Medical College, Trivandrum, and MD from Government Medical College, Kottayam. Then he did DNB in Internal Medicine and Medical Oncology, and also MRCP from Royal College of London, UK. He is a member of various organizations in India as well as abroad. And he regularly conducts classes for nurses and doctors on oncology and chemotherapy. And he has a few articles to his credit. He is an active participant in various conferences. So I welcome Dr. Suneesh also to this session. And first of all, I would like Dr. Manu to speak about the basics of radiation oncology, and then Dr. Suneesh will be speaking on medical oncology. So it's over to you, Dr. Manu.
Okay, thank you, sir. Can somebody upload the slides, please? I already sent it there.
Sorry, Stephen.
Yes, sir. Yes, sir. I'm just taking it. Since too many windows are open, just a small listen opening the slide and right away share. Dr. Manu?
Yeah, okay. Can we start? Am I audible?
Yes, you are audible. Please go ahead.
Okay. So good evening, everyone. Today we'll have some basics on radiation oncology, especially those who are dealing with cancer patients and all. we should be aware of the basics at least. So can we go to the next slide? So radiation, that's a basic therapeutic use of high energy ionizing radiation in the treatment of malignancies. We have two types of radiation which is used in the treatment purposes. It's basically electromagnetic radiation as well as a particular ionizing radiation, out of which we commonly use electromagnetic radiation for the treatment purpose, and the X-rays and the gamma rays, they come under the electromagnetic radiation category. And regarding the particulate ionizing radiation, we have electrons, neutrons, and all. Commonly we use electrons. Next slide, please. So X-rays are the basic radiation which we use nowadays, and gamma rays are not used recently because new machines we have linear accelerators. So all of these make use of the X-rays. So these X-rays are produced as a result of abrupt mechanical deceleration of electrons hitting a heavy target like tungsten. So that is the principle. And whereas gamma rays are usually produced from natural isotopes like cobalt. Next slide, please. So this is typical, just a picture of how a linear accelerator, it's there, which is commonly used now. We don't use much of cobalt machines nowadays. So there's a stand, there's a fixed stand, and we can see a couch where the patient is lying down, and the part which rotates around the patient as well as the tumor, that is known as the gantry, that rotates around a 180 degree or 270 degree or 360 up to 360 degree. So the electron, the source of the radiation is this gantry. So what happens is electrons are shot at high speeds, and that hits the target, which is almost over the patient, and as a byproduct, the X-rays coming out. So we focus the X-rays, high energy X-rays, that is which is used in radiation, that falls over the patient, and we adjust the electromagnetic fields around. Can I go to the next slide, please? Okay, how this affects, it's used in cancer treatment. Basically, we have two effects: the molecular effects and the cellular effects. Usually, the radiation that should produce at least double-stranded DNA break to kill a cell. Also, the radiation interacts with the water inside the cells to generate free radicals, and this causes cell damage mostly. And the other effect is the cellular effect, and wherein mostly the cells will be most sensitive in the G2 phase, whereas most resistant in the S phase. And usually the radiation we prescribe in gray unit. That's what we find in the prescription of the cancer patients, gray or centigrade. Usually gray, that's the most common used prescription term. Next slide, please. Okay, this is just a picture of a linear accelerator or a radiation machine, whatever. And the patient lies on the couch, treatment couch, and the accelerator part or the radiation machine, that gantry part, gantry we call it, that rotates around a particular axis to execute the radiation. Next slide, please. Okay, another type of radiation is, okay, can I just see the previous slide, one second? Okay, the external beam radiation, the thing is the radiation source or the radiation, the area from which the radiation comes out, that's kept at a distance from the patient, not very in proximity, usually 80 centimeter or 100 centimeter distance. So that comes from a distance. Next slide. The next one is the brachytherapy, which is slightly different from the external beam radiation. In the brachytherapy, we know that radiation is delivered inside the tumor or very close to the tumor, and the radioactive source is usually kept in a sealed container when not in use, and that's taken out only at the time of radiation. And the most common type of brachytherapy, there are subtypes also. The most common types of brachytherapy are interstitial brachytherapy, intracavitary, intraluminal, and usually the what commonly we use is interstitial brachy. That was earlier it was used widely, especially for CA tongue and CA prostate, CA cervix and all. Nowadays, interstitial brachytherapy we use mostly for CA tongue. And next one is the intracavitary radiotherapy, that is radiation executed inside a cavity like rectum or cervix, that we use intracavitary. It's the term is intracavitary. In case you use for CA esophagus, you need to give radiation inside the esophageal cavity, that lumen. we use intraluminal brachytherapy sources for that. And the next one is on intravascular radiation is also there in case of that we don't use commonly, but that's there in the literature, where in case of recurrent coronary artery block, to relieve that block, intravascular radiation is used. That is another purpose. And another type of brachytherapy is surface molds, especially in case of skin cancers or in case of ocular cancers. Surface molds are used to deliver radiotherapy. Next slide. Okay, this is just a picture to show interstitial brachytherapy, wherein needles are inserted into the prostate or the tumor part under ultrasound guidance. And similar radiotherapy is there for the cervix also, where we have implants inserted into the disease affected area. But nowadays, of course, this is a bit painful and needs sedation, anesthesia. Nowadays, we have better facilities for treating prostate cancer. So usually we use the most modern linear accelerators, IMRT, other facilities for executing radiation to the prostate. But even for cervix, it is this used. Sometimes it's used. Next slide, please. Okay, another type of radiotherapy apart from the external beam radiation and the brachytherapy is the systemic radiotherapy. That is the isotope therapy, wherein where the nuclear medicine department is involved. There, the non-sealed radioactive source is used, either intravascular or enterally. We can take it orally. Such a treatment is existent for especially in case of carcinoma thyroid that's present for the past many years. After CS thyroid surgery, you do the iodine 131 study, and in case there is uptake, you do the radio-ablation again using isotope therapy. And recently, nowadays we have samarium therapy for bone lesions, and strontium therapy is also there for bone metastasis. One thing is this isotope therapies, that's also costly, and that needs admission to the facility and watching the patient for 1 or 2 days till the radiation is over. That exposure is over, so that others also will be safe once the patient gets out of the radiation room. Next slide. Okay, in which all settings we use radiotherapy? What all are the indications of radiotherapy? Or there are some terminologies which we hear commonly. We'll just see what it is. Like there are 5-6 categories commonly used. One is curative radiotherapy, wherein we give radiotherapy with a curative purpose to cure the tumor. Next one is adjuvant therapy, adjuvant radiation. And another one is concurrent chemotherapy with radiotherapy. That the details we'll see in the coming slides. There is a neoadjuvant radiation, also known as anterior radiation, and we have the palliative radiation, the prophylactic spinal radiation. Next slide, please. Okay, what is this curative radiotherapy? Curative radiotherapy means for a particular tumor, radiation is the treatment. Such treatment or such radiation given with such a purpose is known as curative radiotherapy. That comes in the case of early stages of CL larynx and cervix cancers. So we give radiation with a very curative purpose. And sometimes in case of CA lung and carcinoma anal canal or CA urinary bladder or Hodgkin's lymphoma, and some case of early prostate cancers, this curative radiotherapy is used. Just for an example, 70 gray in 35 fractions. That is a dose prescribed. That means 70 gray radiation is executed in 35 sittings, 35 fractions, wherein almost 2 gray will be given each time. This is an example for curative radiotherapy. Can we go to the next slide? Okay, so what is adjuvant radiation? Earlier was curative radiation. What is adjuvant radiation? Adjuvant radiation means the definite treatment of a particular cancer is something else other than radiation. It can be surgery or can be chemotherapy. And we give this adjuvant radiation after the particular treatment. Example, in brain tumors like glioblastoma or in carcinoma breast, that is a definite surgery is a treatment, wherein you do that followed by radiation so as to prevent local recurrence. That is the purpose of adjuvant radiation. Okay, that comes also for the like cases of CA rectum and any CA cervix or endometrium, local advanced head and neck cancers. That we give adjuvant radiation. Next slide. Okay, another type of radiation is concurrent chemo radiation, CCRT. That is where both radiation and chemotherapy both are given together to give better results than each one using separate. Sometimes we give chemo, like in case of brain tumor, on the days of radiation, you give temozolomide tablet also to get a better coverage, or 5-fluorouracil in cases of CA rectum. So that is concurrent chemotherapy. Of course, side effects will be slightly higher, but effect also will be higher. So in cases where you feel that, or in intermediate case or high risk cases, you use this modality so that you get better results. Another modality is neoadjuvant radiation, anterior radiation. That is the definite treatment is something like a surgery. You give radiation before doing the surgery to downsize the size of tumor so that resectability will be better and the clearance will be better. That is a neoadjuvant radiation. Next slide, please. Okay, palliative radiotherapy, which many advanced cancer patients will be receiving. That is, palliative radiotherapy is given with an intent of palliation to provide comfort for the patient. That is a sole purpose, not the cure. So most commonly it is used for relieving pain. Another one is bleeding, to stop bleeding. And if in some cases, if you have dysphagia, metastatic disease of esophagus and all, but you have dysphagia, you need, you try to provide some comfort to the patient to improve the dysphagia. That also, in that case, also palliative radiotherapy will be useful. And like in case of chest wall, carcinoma breast, huge mass and all, you need to downsize it, or chest wall recurrence to relieve the symptoms. Then you give palliative radiotherapy. Palliative radiotherapy is usually given as either single radiation or multiple doses, like 30 grain 10 fractions or 20 grain 5 fractions, depending on the health of the patient as well as the disease, the type of disease and all. And there's another entity known as prophylactic craniosspinal radiation that is usually used in cases of primary brain tumor with high chances of brain and CSF metastasis. Okay, in such cases, prophylactic craniosspinal radiation is also used. Also, in case of high risk for brain metastasis, like small cell carcinoma lungs, you complete the chemotherapy. You find that the tumor has responded well, but there is a high probability of brain mets later on. So in that case, also you do prophylactic craniosspinal radiation. Next slide, please. Okay, the older radiation techniques, they are usually two-dimensional, 2D. You may have seen the patients with the drawings, markings on the face or places. You give the lateral radiation, right lateral, left lateral radiation, to field radiation and all. But there is a primitive one. But nowadays we use 3D, of course, with the help of CT scan imaging. There and we use this treatment planning system also to delineate the tumor as well as to mark the normal structures, so that we can give better dose delivery to the tumor at the same time sparing the normal cells. Okay, for 3D radiation, you need to immobilize the patient so that patient will not be moving during the radiation, so that the correct radiation will be going to the tumor and the normal tissue will be spared. Next slide, please. Okay, this is just an image to see to show how the 3D radiation thing works. Like that, you deal in the tumor as well as the normal structures and execute the radiation from the multiple sites, multiple fields. Next slide, please. Okay, then comes a IMRT. That is a slightly high advanced form of 3D RT. Usual radiation we give, you used to give using a square field or a rectangular field. Okay, that was the only thing possible previously, wherein nowadays we have the better facilities, IMRT. There, instead of only the 4 fields, we have multiple fields, or rather the radiation will take the size of the exact size of the tumor, so that the normal structures will be spared. The other one, you get the radiation to the tumor, but a lot of normal tissue also will be affected. So IMRT is more specific. Okay, this is a highly advanced technique wherein you use multi-leaf collimators, MLCs we call it. multi-leaf collimators take the shape of the tumor, and we will get better results and sparing the normal tissue. Next slide, please. Okay, these are another slightly modifications for these techniques. Where an IGRT means image guided radiation. That's a method of radiation that incorporates imaging techniques during each radiation treatment. During each therapy, you do imaging and see any position change or any tumor reduction. So you treat accordingly depending on the imaging every day. Sometimes you need to image only weekly once or twice, but some cases you need to image daily. So that is also possible nowadays. The another one is respiratory gating. It's an innovative process wherein, like CA lung cases, the patient breathe in and out. The tumor also will be moving along with the chest wall. So there's a high chance that the radiation will miss the tumor and radiation will go to the normal tissue. So in those cases, respiratory gating will be very useful because this tumor will be marked by an infrared camera, and the tumor exactly will get the dose, radiation dose. The normal areas will be spared. Next slide, please. And we have other techniques like the stereotactic radiation or stereotactic radiotherapy. This is therapy using high dose radiation executed within either a single fraction or multiple, say 3 or 5 fractions. Instead of the 70, the other ones we use 70 grain, 35 fractions, or 35 times will be 35 days will be taken. This one is stereotactic therapies will be very short time consuming. It will be finished either in a single day or a few days. Of course, the machines also, they are very high-fi machines are used for executing stereotactic radiotherapy. They are used in cases where there is difficult to operate. Some types of brain tumors which very close to the normal structures, you sure you cannot take it out. Those cases, or ablation of AV malformations, ocular melanomas, such difficult cases, these stereotactic therapies are used. Even in nowadays, liver cancers, isolated liver cancers, or 2 or 3 liver cancers, isolated ones, which you can treat with the help of stereotactic radiotherapy. Next slide, please. And these are the procedures usually coming for for radiation execution. And just to tell you what all happens, how we plan and how we execute the radiation. A few 7 steps are there. One is immobilization mask. Immobilize the patient so that patient won't move during the planning as well as the radiation execution time. Step 1, immobilization. That is, you use plastic sort of mask. There is a particular material is there. You shape the mask according to the shape of the patient, and you fix the patient to the underlying board, so that and you plan take the imaging only after immobilizing the patient, so that you get the patient on the same position every day. So the make sure that patient is there, is keeping the position every day. That is the step 1. And after immobilizing the patient, you take planning CT images or PET CT images. And then you, in the 3rd step, you see these images and you do something known as contouring. Contouring means you draw imaging, there are few lines which you draw over the tumor. And again, there's a borders you'll put, like the tumor volume, the target volume, and such things are there. You delineate the tumor. And the 3rd step is to plan radiation based on this imaging. Okay, you do the contouring and you make a tumor, delineate it well, and put the fields, 2 field or 3 field or multiple fields. You plan the radiation and see how much dose each organ get, including the tumor, the organ at risk, including organ risk like spinal cord, lungs, heart, or optic nerve. They're all critical structures which should get dose, radiation dose only below a particular dose. So, okay, so we see how much dose each organ get, especially the organ at risk. And you plan, you make 3 or 4 plans, and you see which plan is better. Which plan is better, wherein the tumor gets maximum dose and the organ at risk are spared. And step 5, you execute the the treatment plan is evaluated. Yeah, that's the step 5. And step 6, you set up the treatment. You tell the patient to come on this particular day, and you again you immobilize the patient. The same procedure, immobilize the patient, and you again do the imaging part, and infuse the imaging. Take another time of radiation to the original imaging which you already contoured and planned, and treatment verification and the execution of treatment. This much of procedures are going on for each patient, and immobilization is very important for each radiation, because that decides whether the patient will get abnormal dose or not. Okay, next slide, please. Okay, there are a few side effects for radiation, of course. There are acute side effects and long-term side effects. Acute side effects we see very commonly. Previously, it was even more with the when we use the cobalt machines or the 2D technique. Now it's slowly coming down. But still, side effects are there. Common side effects are the skin reactions. There's a grading also 1 to 4, and mucositis grade 1 to 4. Nausea, vomiting in case if the bowel is there in the radiation field. Loose stools may be there. Myelosuppression also may be there. So sometimes you'll have to check blood counts whether it's going down or not at the time of radiation. Next slide, please. And regarding the skin side effects, grade 1 means that's only mild erythema, slight redness will be there. And grade 2, there will be mostly dry desquamation. There will be slightly blackish coloration, or skin starts to peel off, but slightly, slowly. Grade 3 means peeling of skin is there, but you'll see a raw area, red area, wherein sometimes slough will be there. And grade 4 means is a severe bleeding or ulceration of full thickness of dermis. That is a grade. When you reach grade 4, sometimes you'll have to stop radiation for some time to for the patient to recover. And one important thing is we'll tell patients to watch the area without scratching. Or patient may wash the affected skin or the radiation area, but you have to dry it with a soft, clean towel before each radiation session. You can just mop it, but you cannot rub it. Okay. Sometimes topical steroids are prescribed for radiation dermatitis. Next slide, please. Okay, this is pictures of first one was just mild erythema. Second one, no, the bottom one you can see is slight dry desquamation of the posterior area. It's the posterior part of the field. Okay, and next one is there is desquamation more. Slough is there. And the last one is the healing part. Okay, so different categories of radiation skin reactions are there, and we see patient almost weekly once, or if possible daily, to see how much radiation reaction is there. Sometimes you'll have to stop in between also. Next slide, please. Okay, radiation-induced mucositis is also another acute side effect, wherein grade 1 is just erythema, grade 2 is patchy reaction, here and there reaction, and grade 3 is confluent mucositis. That is, the reaction is that's fused together, multiple areas, but almost fusing together. Grade 4 is ulceration, necrosis or bleeding is grade 4. That is the RTOG, that's the radiation oncology grouping for this radiation-induced mucositis grading is. Next one is, next slide. This is a WHO toxicity scale, mucositis scale. This is grade 1, again, soreness or red color. Grade 2 is erythema or ulcers. You can see the picture wherein there are here and there are patches, but grade 3 means more patches or small patches will be fused together. You can see a uniform discoloration. And grade 4 means more mucositis and sometimes ulceration, bleeding. Next slide, please. Okay, now how to manage this oral mucositis? That includes the following. Like, one is the pain control. That may be a main issue. Patient may be having severe pain. So for that, you need analgesics and like gel, oral gel that might help. And nutritional support is very important. Oral contamination. Patient may have to use mouthwash regularly, diluted mouthwash to clean to make the area clean, and to control pain and control bleeding. Palliation of dry mouth, that is also very important. Management of oral bleeding, that is also another issue. In case of bleeding, that case we stop radiation and give time for recovery. Usually grade 1 or 2, mouthwash with saline and will be enough. And grade 3, you need antibiotics and analgesics. nutrition is very important. So if the patient is finding it difficult to swallow, or your patient is losing weight, you'll have to go for rice tube feeding or peg tube insertion. Sometimes some patients already, if not taking food properly, we do the peg tube insertion even at the time of radiation. May not wait for long. Okay, and radiation is usually stopped at grade 3 mucositis or grade 4 mucositis. Management also include avoid irritating or abrasive substances. Use of bland rinses, that's better suggested, and dilute the mouthwash. And topical anesthetic agents will be useful, and systemic analgesics also will be useful. Next slide, please. And especially patients on radiation, what to avoid. One is to avoid sun exposure by covering the area, the field, radiation field. And topical irritants like perfumes, alcohol, deodorant, such should be avoided. And scratching of skin should be avoided, and tell the patient to cut the nails and keep the area clean, and avoid shaving the particular area at the time of radiation, because that skin will be very soft. Next slide, please. And those were the acute side effects. Long-term side effects are also there, like the lung fibrosis, which comes may not be in acute, that comes in the short long-term basis. Patient may be having breathlessness or such difficulties on a long term. So you'll have to consider this also in mind when you see such a patient. And GAT side effects are there, like nausea, vomiting, that may persist for some time. Sometimes strictures may be there after a long time as a long time side effect. And sometimes you'll have rectal telangiectasia, bleeding, that also can happen as a long time side effect. Even same with the bladder, urine bladder also may be having some telangiectasia as a long time side effect of radiation. For brain, you'll have leukoencephalopathy, seizures, or cognitive defects, that may be side effect. Regarding skin, edema may be there long time, persisting may be there for some time. And regarding bone, osteoarthritis necrosis, it's very problematic side effect, long-term side effect. The myelosuppression also, that may persist for some time, even after radiation to pick up. And regarding spine, usually head and neck radiation, maybe after a particular radiation dose, we spare the spinal cord. In case more radiation go to the spinal cord, that can cause problems like Lermit syndrome or incontinence. And liver also may be having long-term effects with radiation, like cirrhosis or hepatitis. And cardiac side effects are also there as long-term. Next slide, please. And osteoarthritis necrosis, that is a problematic one. That's more common after radiation for head and neck malignancies due to the superficial position of the mandible. So that gets exposed to radiation much. So in such cases of head and neck radiation, usually we advise the patient to have a good oral hygiene and to do any dental procedures necessary before starting the radiation, so that such problems can be avoided. And sometimes patient having dental issues but not addressed before radiation, so you go for a dental extraction or procedures after the radiation, so that can cause delayed healing. And osteoarthritis necrosis also, that may be there, that also an issue. So addressing the oral cavity and dental part before starting radiation is very important. And next slide, please. Yeah, sometimes it will be like this osteoarthritis necrosis. We'll have severe pain and issues. And treatment part is not easy. Sometimes you need curating, and antibiotics will be necessary. Sometimes we have to resect that particular area. That also will be there. That also will be needed sometimes. Can we go to the next slide? Okay, there is something else known as medication-related osteonecrosis of the jaw. Okay, that describes the bony destruction of the jaw. Again, mandible, that's more at risk. Okay, that's in the presence of current or previous anti-resorptive or anti-angiogenic medication, like the injections, like the bisphosphonates and all. That use can cause medication-related osteonecrosis later on. Okay, in the radiation is not used in such cases, but such cases just due to the medications, patient may have medication-related osteonecrosis. Next slide, please. Okay, okay. This is just another X-ray picture and the clinical picture of medication-related osteonecrosis. Can we go to the next slide? Okay, which are the tumors which are really radio sensitive, which are useful in those cases which we should go for radiation? This one is Wilms tumor, of course, very radio sensitive, and myeloma is very radio sensitive. Lymphomas are very radio sensitive. Seminomas and dysgerminomas are radio sensitive. Ewing sarcoma, even if it's a huge tumor, when we give radiation, it melts like wax. That's all. That's what described. It's very radio sensitive. And carcinoma larynx and CS cervix are very radio sensitive. So in such cases, we definitely expect a good results with radiation. Next slide, please. Whereas some malignancies are comparatively radio resistant. You may not get good results for those radiation with radiation, like in case of osteosarcoma or hepatocellular carcinoma, carcinoma pancreas, or melanomas especially are not at all radiation sensitive. So there's not much use in giving radiation in such cases. But it's say pancreas, sometimes we give radiation for relieving pain, and hepatocellular carcinoma, no radio resistant as such. Stereotactic radiation is useful in some cases. And common tumors that respond well to radiation therapy, again, we already mentioned that. Can we go to the next slide? Okay. Okay, that's it. Thank you.
Thank you, Dr. Manu. And now we'll move on to the second part, medical oncology by Dr. Suneesh. Suneesh, it's over to you. Please unmute, Dr. Suneesh. You are muted.
Can I share my screen? Is it audible?
Yes.
Can you see the slides?
Yes.
Okay. Good evening. So, am I audible?
Yes.
Okay.
You are
We had a wonderful talk by Dr. Manu regarding the basics and the principles of radiation in treating malignancies. So we will go a bit more deeper into the how a cancer behaves, or what is how the therapeutics is working in cancer. You will be having some questions regarding what makes a cancer, how a cancer gets into other tissues. So after all, we have reached so much of advanced scientific knowledge. Why can't we cure cancer 100% by this time with all modalities available with us? So how a cancer cell grows, that makes its uniqueness. That makes I think it's a evolutionary advantage of the cancer cell. As we got some advanced cognitive and other metabolic achievements by our own evolution, like that the disease cancer is having multiple facets. It's not a single entity. It is having some so much deeper mechanisms that makes it's particular, so that it is not easily controllable thing. So what are the medical oncological principles that helps in curing a cancer? That's what we are going to discuss. So you will be knowing that the cancer treatment options include so many armamentarians are with us. Like the majority of the cancers, the major thing is surgery, then radiation, then comes the medical things like hormone therapy, chemotherapy, then immunotherapy, radiation, targeted therapy, and bone marrow transplantation for leukemias and lymphomas. So we are having so much things to cure cancer, but still we are some behind that. Why is that happening? And what is the exact role of a medical oncologist in this scenario? So it's like sometimes medical oncologist is like a conductor of an orchestra. So it's a treatment of a cancer is obviously a teamwork. It's not a single ended thing. So sometimes medical oncologists act as a conductor, like he'll be like the captain of the ship. So we will see what all things. Diagnosis. You will be knowing most of the diagnostic workup after you suspect a cancer will be done by mostly by the medical oncologist. So after that, once you get a diagnosis, planning the treatment. In majority of the cancers nowadays, we do have a multidisciplinary team to decide what is the ideal treatment for that patient. It may be different in different person. So it is not a single-ended decision. So somebody has to take the decision on behalf of the patient. So mostly medical oncologists will be the center person who interacts with all the team, like a surgeon, radiation oncologist, and palliation physician, all people, and then decides what will be ideal for them, and they will discuss the prognosis and direct the treatment. Then comes the execution of treatment. So after the definitive treatment occurs, the medical oncologist will treat with chemotherapy, immunotherapy, targeted therapy, and all other measures. Then following up of the patient, and finally palliative care also will be helped by the medical oncologist. So these are the role of a medical oncologist in treating a cancer. Then comes then we will see we will go into the some basics of how a cancer behaves. Most of the time you will be one of your patients will be asked, like, doctor, my tumor has been removed and I don't have a tumor in my body. Then why should I undergo a chemotherapy? This question you must have heard sometimes. So for answering this question, we have to learn how the cancer grows and how it behaves. So you all know cancer arises from a normal cell. Once some mutation happens, the mutation will make the cell cancerous, and it will go on dividing. It don't have a stop. So it lost the brake, like as if a car has lost the brake. It goes on dividing, and it doubles. It doubles by like a geometric progression. So one cell will go, two will go by 4. Then as it goes on, it will increase the mass, and it has some other properties, like it will loosens the attachment, and it will go through the bloodstream to other organs, and after finding a particular a favorable place, it will end up in growing there also. That's called a metastasis. So all the cancers have some hallmarks, some particular behavioral advantages, so that it can go through these things. So we know every cell needs some growth factors, all those things. Growth factors to grow, and after reaching its lifespan, it should go by apoptosis, and so many things has to happen. But cancer cell doesn't have all these things. So it will grow without any growth factor. It will not have any apoptosis. It will go through the circulation to reach other areas, and it will again grow there, and it will produce its own blood supply. It will get some metabolic advantages, like it will get energy by anaerobic metabolism. All these changes will happen to a cancerous cell. That the uniqueness of the cancer is it is very resistant to all the inhibitory signals from the body. So neoplasia means a new mass of tissue formed due to uncontrolled and persistent growth of or absence of cell death. Can be benign or malignant. We don't care about the benign things, so we are interested in only malignant cells. My question was initially, after removing a tumor, why should we go for a chemotherapy? There comes how the cancer cell grows. I told you it's by doubling. For almost all the cancers to be detected by any clinical modality, it has to reach at least 1 centimeter cube of tissue. The volume of the tissue has to be 1 centimeter cube. So that needs to be it will be around 10 raised to 9 cells to reach this 1 centimeter cube of tissue. 10 raised to 9 cells. So we will be now we can understand the amount of tissue that has to be needed for a cancer to be detected is around, it will be around 10 raised to 9. So you will be knowing that it will take so many years. That's and it will take around usually it takes around 30 doublings to reach around this 10 raised to 9. You'll be knowing this geometric progression 2, 4, 8, 16, 32, like that. If you count on like that, after 30 doublings only, this 1 centimeter cube of tissue will come. And this 30 doublings will take some significant amount of time. That will be depending on, that will be different in different cancers. What I meant is a fastly growing cancer will be reaching this 10 raised to 9 very fast, but a slowly growing cancer will be reaching it very slowly. That will we will see later. So what I want to tell is, it will take 30 doublings to become the cancer to be a size that to be detected. So when you detect a cancer, it should have spread to other organs by its metastatic capacity, and we may not be able to see those cancer cells because it may not have reached the 10 raised to 9 mark. So there will be so many collection of cells that is still yet to reach this 10 raised to 9 marks. So we are treating this micrometastatic disease with the chemotherapy even after you remove the tumor. That's why we need to treat even after you remove a tumor. And this is the condition same as after you induce a leukemia. After the induction, you will do the bone marrow, and it will be saying that your bone marrow is in remission, but you have to continue the treatment for next 6 months. This is the same condition, like even if you kill the cells to a mark like less than 10 raised to 9, there will be remaining a significant amount of tissue that has to be addressed. That's why we have to continue the treatment. So I think that you understood about the 1 centimeter cube and the 10 raised to 9 and the doubling times. Okay. This is a pictorial representation of the same. A tumor cell initiation after 30 population doublings, it will reach around 10 raised to 9. And one more interesting thing is the 75% of the doubling cycles occur before we detect the cancer. So the lifespan of the cancer, if you say it as 100, the 75% will it have passed when you detect a 1 centimeter cube of tissue. So only has 25% remaining. That's only 10 further doubling to reach a size of 10 raised to 12 cells. That is around 1 kilogram of tissue. Why that came is, usually life is not possible with a malignant tissue which is having a 10 raised to 12 number of dividing cells. Everything is important. A malignant tissue with the 10 raised to 12 dividing cells in that is not compatible with the life. So from the 10 raised to 9 to 10 raised to 12 cells, we need only 10 further doublings. So the entire lifespan of the cancer cell will be around 40 doublings. By that time, the host will die. So we will get a narrow window from the 10 raised to 9 to 10 raised to 12. That period we will get to treat the cancer and try to cure the cancer. Okay, so patient will become symptomatic when the size starts at reaching 1 centimeter cube and will continue to be symptomatic. Once the tumor becomes 10 raised to 12, life is not possible further. That means 10 raised to 12 dividing cells. So the 75% of the doubling occurs before the detection of the tumor. And the treatment is possible between a narrow window between 10 raised to 9 and 10 raised to 12. So I told you about the doubling time. It is different for each cancer. We know that the fastest growing tumors will be lymphomas and leukemias. And in lymphomas, Burkitt lymphoma is having the shortest doubling time, that is 1 day. So that means it will double the volume by every single day. It will double the volume. So the 30 doubling times will be within 30 days, and the 40 doubling times will be in the 14 days. So you can imagine that a patient started having Burkitt lymphoma on day 1, will be symptomatic on day 30, and he may die in day 40 even if we don't detect the cancer on day 30, and if we don't give any treatment by day 13, he may die on within 10 days, next 10 days. That's the significance of this doubling time. The leukemia is also having a faster doubling time, less than 1 day. And another fastly growing tumor is choriocarcinoma. And acute lymphocytic leukemia is lymphoblastic leukemia is having 3 to 4 days of doubling time. Hodgkin lymphoma by 3 to 4 days. Testicular tumors by 5 to 6 days. And once we go to the solid cancers, the doubling time is significantly higher. Like in colon cancer, almost all the adenocarcinomas we are having around 3 months. We can generally tell it is 3 months. And lung cancer, it is 90 days. And breast cancer is also comes to around 90 to 100 days. And squamous cell carcinoma is having a slightly lesser than like 70 to 90 days. So this is the importance of learning this doubling time, because once the solid tumor comes, the 30 doublings will be around I think up to 5 years. So that means once a cancer cell start developing in your body in a solid tumor, it may take around 5 years to get into a size so that it will reach around 1 centimeter cube. So you will be getting 5 years time before, even if with the cancer in your body growing for 5 years, and you will be detecting that cancer once it has grown for 5 years in the body. But in the next 1 year, it will be reaching a 10 raised to 12 size, 1 kilogram of size, and you may be dying. So you will get enough time to diagnose and treat, not like the Burkitt lymphoma. So this is a pictorial graphical representation of the same. So if you plot the tumor cell burden in log scale and the number of doublings, you will be you can see that there is a linear relationship. From the relationship is linear to the 10 raised to 9 mark, and up to 10 raised to 12, you will 1 kilogram of mass will be there, and death will be eventually occur. So we are detecting the tumor at the 10 raised to 9 mark, the 1 centimeter mass. So we are giving some kind of treatment, some curative initial therapy. So by that, the number of cells will become, it will be less than 10 raised to 3. 10 raised to 3. That's the curative amount of the cells that how a cancer gets cured is by finally by our immune cells detecting the cancer cells and eliminating from our body. Our chemotherapy is not able to eliminate the cancer cell. 100% of cells cannot be killed by the chemotherapy. Finally, our immune system has to eliminate the residual cells. That's once it is less than 10 raised to 3, the immune system will kill all the cells. When it is less than 10 raised to 6, it means we are in remission. Less than 10 raised to 6. That is what's seen in this next line. In the non-curative therapy, it's almost reaching the just above the 10 raised to 3 mark. And we are getting another significant amount of time to again the patient becomes symptomatic. This is what we are doing with the palliative chemotherapy. The first thing was the curative therapy. The another thing is the palliative therapy. In the curative therapy, what happens is from the 10 raised to 9 cell, we are reaching less than 10 raised to 3 cells, so that our immune system will kill all the other cells. But in what happens in palliative therapy is we are reaching from the 10 raised to 9 just above the 10 raised to 3 mark, so that for some time the cells will not be producing some symptoms, and it will get some more time to again become that 10 raised to 9 according to the doubling time, maybe around next 3 or 5 years, so that he will become symptomatic again. So that's what the how the growth of a cancer cell occurs. Then comes, I told you, it's a evolutionarily highly advanced disease, the cancer. It's not like other diseases anywhere. There is no comparison for cancer with any other disease. So we are trying to understand the enemy better and better. So one of the initial proposed theory was that it's following a Gombertsian model. Gombertsian model is, it's like our, it's applicable to every population, like our own population. What happens is the tumor cell will grow initially by a lag phase. Then there will be an exponential growth of the tumor cell. Finally, it will reach a plateau. This is how the Gombertsian system applies. In lag phase and plateau phase, the growth is slow, and in log phase, it is exponential, maximal. So this is the pictorial representation of the same. So there is a lag phase and there is a steep growth. And once it becomes 10 raised to 9, and from the 10 raised to 9 to 10 raised to 12, it is the plateau phase. So that is the phase in which we can clinically detect a cancer and we can give some treatment. But in the clinically undetectable phase, it is growing at its maximal level. So this is the maximal growth phase in which the cancer is growing. But after you detect a cancer, it is not that much fast. This is important. Why? That we will come to later. So this is another explanation for the same thing. It's a Gombertsian curve showing the growth, and you are treating from the 10⁹ mark with the chemotherapy, and it is showing a downward trend towards the cure. Okay, so from the 10⁻12 mark, if you do a surgery or radiate or intensive chemotherapy, you may reach this 10⁵ cells. So after that, what happens is immunotherapy, immunity of the our host will try to cure the disease. So these are some observations like growth fraction. What is the growth fraction? It is a fraction. It is the amount of cells in a tumor that is actively dividing. That the fraction of cells growing will fall exponentially over time. That means once the tumor growth occurs, it increases. The number of dividing cells will become less. And the growth rate peaks. I told you it is in the preclinical phase. It is the maximum, and will decline after that. And it will reach a plateau, so that the division of the cells and the death of the cells will be equal, and predicts the pattern of growth. It's same as the micrometastasis that is happening. And the tumor growth rate is maximum at the 37%, once it has reached the 37% of the total tumor volume. It's another explanation. It's a log linear, the growth phase, a small tumor, initial growth is first order, the same thing. It's also the same thing. So there will be some, you cannot explain everything with a single law. There will be limitations, like growth of mass is more complex than cellular proliferation. No tumor grows exponentially, and doubling time increases as the tumor gets more size. As tumor growth fraction of cells in growth phase is decreasing, you can understand this way. Once the number of cells increases, there will be a limitation of the supply. There will be a demand supply mismatch that will be happening. So once this happens, the pattern of the growth will be entirely different. You cannot predict about that. You need to have a neovascularization, so that you will be getting adequate blood supply till the end, so that the cells will be rich with all the micronutrients to grow. So these things come into play. There will be limitation to explain by this Gombert's law. So this is another explanation. If you imagine, if a cell is growing and dividing, it's like a spear. You cannot, the spear cannot expand maximum. So at a point of time, the spear has to cease the growth. So that's why the tumor is not growing like a spear. It is a fractal growth. Fractal growth means arborizing pattern. You will be seeing that in the radiation pattern, it is given like, it is like the edges of the tumors are not a perfect spear. It's a arborizing. It's the front of the tumor is growing, so that the length of the tumor increases, the volume of the tumor again increases, and the number of cells dividing also increases. This is a concept just to understand. So another thing is a famous hypothesis that put forward by Norton-Simon. It's called the tumor cells are killed by chemo drug at a rate proportional to its growth rate. So you will be thinking that once you give a chemotherapy, every tumor has to be responded uniformly. But it is not the same thing that is happening. Why that is that problem? That's explained by the Norton-Simon hypothesis. It is saying that if a tumor is growing very fast, your chemotherapy also will be having the maximum impact, so that the number of cells in the dividing phase will be maximum, and the chemo can kill. Not only the chemo, the radiation, everything can kill the maximum number of cells. That's what explained by this Norton-Simon hypothesis. So rapidly growing tumor will have a more cell kill with a chemo drug, and the rate of tumor volume regression is also proportional to the growth rate. So consider a system in which chemotherapy kills a certain percentage tumor cells. So the chemotherapy cannot kill all the cells in a single shot. It will kill a certain percentage of the cells. That's called, it is following a first order kinetics. It is killing a percentage of cells. So but you cannot give chemotherapy daily. It will have a break in between. But by that time, what happens? Again, this tumor will grow. And it will reach another set point, so that the next chemo will again kill a certain percentage of that tumor, and it goes on. So in generally, it is said that a chemo will kill 2 log reduction. That is around 2 log means 10 raised to 2. And by the time you give the next chemo, there will be a 1 log increase in the tumor cell. So ineffectively, in between the chemotherapy, there will be a 1 log reduction in the tumor cells, around 10 raised to 1. This is also important that you have to understand. There will be a 1 log reduction in the cell number with each chemotherapy. So for the best treatment, after you understanding the Norton-Simon hypothesis, what we can say is, if you treat a small tumor that is growing at its maximum rate, it is best for a chemotherapy to act. And if you give the highest possible dose, that will be having the maximum cell kill. And the time interval between the chemotherapy cycles should be minimum, so that the number of the next division will be less. And the shortest period of time duration also, it has to be less. So all these things coming together, we are giving the dose dense chemotherapy. That is we will see what is this dose dense chemotherapy and all later. So the other things, now you understood how the cell grows, how the tumor cell grows, how our chemotherapy acts, and it will be easy to think that our chemotherapy will kill all the cells and the body will be cured of the cancer. But it is not happening. Why? Why? Because tumor is getting resistant to our chemotherapy. So what is making that resistance? There are so many mechanisms that produce resistance of particular tumor cells. There are some explanation for that. One is Delbruck-Luria model. It's just an observation that if you culture some bacteria in some different petri dishes, even if you infect it with a bacteriophage, these things will get resistant. So even if you don't give any chemotherapy, the cells are getting resistant. Why? Because it is explained by another theory called Goldie-Coleman theory. What it says that it is not the exposure to drug that makes the cells resistant. It is the number of divisions that makes the cell resistant. You can simply understand, because as the number of divisions increases, it is getting newer and newer mutations in the DNA, so that there will be hundreds and hundreds of heterogeneous cells will be there, and 100 cells will be having 100 different particulars. So some of them will be resistant to some drugs. That's what explained by this Goldie-Coleman hypothesis. So what this explains is, as the number of division increases, there will be chance of getting resistance. So it is calculated that every 100,000 to 1 lakh cell, there will be a resistant cell in that group for chemotherapy. Another thing is Skipper law. This is a simple thing. You will be you understood that we are getting enough time before we get diagnose a cancer. Like for in the case of a solid tumor, it will be around 5 years. But once you diagnose the cancer, the deterioration is very fast. Why? That is explained by the Skipper's law. It means the doubling time is a constant, and it will take same amount of time to become from 1 cell to 2 cell, and 1 gram to 2 gram, and from 500 milligram to 1 kilogram. So the final progression will be very rapid. What happens? It is the reverse is also same. That is, the chemotherapy can kill a certain percentage of cell, like around 90% of cell, whatever be the tumor remaining. If there is a 1 kilogram of tissue, 90% will be killed by the chemotherapy. And the remaining 100 gram, 90% again will be killed by the chemotherapy. So the cell kill is again following a first order kinetics. So this is what I told again before, that by each chemotherapy course, a 2 log reduction will be there, but by the time a 1 log regrowth will occur. This explains the number of adjuvant cycles that we will see later. So there are again some limitations of the Skipper law, like it is applicable only the stem cell compartment. It's not the G0 phase, it cannot explain. And malignancies with a early stage and readily curable cancer we can apply. Okay, so after knowing all these principles, then comes the combination chemotherapy principle. So what happens is, if a drug can kill 90% of cell, and B can again kill 90% of cell, by combining A and B, it will kill around 99% of cells. Only one will be remaining. And another cell you give, another drug you give A plus B plus C, then it will be 99.9% of cells will be killed. So what do you mean by this is, without increasing the individual drug toxicity, you can achieve around 99.9% of cells kill by combining these 3 drugs. So the putting all these together, faster growing tumors will respond to chemotherapy very effectively than slow growing tumors. So we can see more response in a high grade poorly differentiated tumor may respond better to chemo than a well differentiated low grade tumors. And chemotherapy and radiotherapy cannot act in the G0 phase of the cell cycle, where the cells will be in the dormant state and it is not in the dividing phase. So what we are achieving by a cytoreductive surgery is we are putting more and more cells into the growing phase from the G0 phase. Coming to the therapeutics, this is the main thing is the intent of treatment is broadly divided into curative and palliative. And the most important driving principle is primum non nocere. That means we are not, do not harm. So another major important law is law of by Loeb, Robert Loeb. So it's just for an interesting thing to just understand. The first law is what you are doing is doing good, keep doing it. Like if you are giving a chemotherapy and it is having some particular action in that, continue the chemotherapy. But it will not be same as in all case, because you cannot continue the induction chemotherapy or adjuvant chemotherapy for a long time. And second law is what you are doing is not good, stop doing it. Like if you are not getting any particular response, please stop the chemotherapy without producing much harm. But this is also cannot be applied to every situation, because even if you produce some side effects with the chemotherapy, we will continue it, thinking that you can cure the cancer. Third law is, if you do not know what to do, stop doing, do nothing. This is particularly important because there is a time pressure that will be seen from the start of the diagnostic delay. So you cannot give chemotherapy without a particular, without getting a histological diagnosis and without proper consultation and all. You cannot jump into chemotherapy. That may have some problem. And fourth law, never make the treatment worse than the disease, because quality of the life versus duration of the life, that's much important. Some people will like less duration with a proper maximum quality, and it is not a kindness to defer death only transiently by rescuing a dying patient back to the raft of suffering. These all things are very much important when you are treating a palliative in the palliative care, palliative setting, metastatic setting of disease. So, what are the terms? Like you have heard in adjuvant radiation, like that. It's the chemotherapy also divided into certain groups, like primary induction treatment. What do you mean by that? There is no other treatment possible. Only chemotherapy is possible. This is called the primary induction treatment. This will help in downstaging the tumor and may facilitate local therapy. Another thing is adjuvant treatment. What do you mean by that? After surgery or some kind of definitive treatment, you are trying to prevent the local recurrence or metastatic recurrence. That's what we achieve by adjuvant treatment. Neoadjuvant treatment, what is that? It is before the definitive treatment, like you are going to do a surgery, but the tumor is big, you cannot operate. But you can, it is said that you can reduce the tumor volume by chemotherapy. That's what we are doing in a neoadjuvant treatment. Then maintenance therapy. What is that? Maintenance therapy is you have given the chemotherapy and you have achieved, you got a better result. But you think that by continuing the treatment, you can delay the recurrence of the disease, or you can continue the complete remission for some more time. That is maintenance therapy. Another important thing that will be helpful for palliative patients is metronomic chemotherapy. What is that? Metronomic means you are giving a chemotherapeutic drug at a low dose and continuously for some time, so that the mechanism is different from a chemotherapy. We discussed all these laws, no? Skipper law, all those are not acting in this metronomic chemotherapy. It is entirely different, because the metronomic chemotherapy mainly acts by inhibiting the neovascularization. That's the major mechanism of action of this metronomic chemotherapy. There are some other minor effects also, like you are stimulating your immune system so that it will kill some part of the tumor tissue, and you are stimulating the apoptosis in the tumor cells. All those things are coming together to help to define the mechanism of this metronomic chemotherapy. Concurrent chemotherapy, that's what discussed in the radiation also. You are giving radiation and chemotherapy together. It is why that is giving, because you are combining a local treatment with a systemic treatment. Two things are taken care of same time. Like you are treating the local treatment with the radiation, and the systemic disease, like that is what we call the metastasis, micrometastasis by the systemic treatment. And there is another advantage also. These chemotherapeutic drugs will increase the radiation effect in your body. That's what we are getting in the concurrent chemotherapy. So definitely there will be increased toxicity, but the effect also will be slightly higher. So after hearing all these boring principles, some interesting things we will discuss. Why, what the chemotherapy achieved by these days? Is there any curable cancer with the chemotherapy? There are a lot of cancers that can be cured by chemotherapy only. Example, childhood ALL and some adult ALL. You cannot cure all the adult ALL, but some of the adult ALL can be cured. Acute promyelocytic leukemia, it is a chemo-curable disease. Some AML. Germ cell tumor, it's again a chemo-curable disease. Choriocarcinoma, Hodgkin lymphoma, Burkitt lymphoma, certain percentage of the diffuse large B-cell lymphomas and some NHLs, follicular lymphomas. All these things are curable cancers with the conventional chemotherapy only. So, is there any tumors that can be controlled with the chemotherapy? Nowadays, there are lot of newer things coming into our therapeutics, like small molecules, targeted treatment, immunotherapy, all those. Now, there is a change from the you are dying with a metastatic disease to you are living with a cancer, like you are living with diabetes, you are living with CAD. Now, what is happening? You are living with a cancer in the stage 4. The best example is CML, chronic myeloid leukemia. You are living with this chronic myeloid leukemia in CP with imatinib only for next 10 to 15 years without any much problem. Then coming to the chronic lymphocytic leukemia with the TKAs like ibrutinib and all, you are living for next 3 to 5 years without much problem. Multiple myeloma, so many newer drugs has come, and even if no cure has been achieved with for multiple myeloma, but you are living with multiple myeloma for next 7 to 10 years. Then metastatic cancers, like you are treating with a targeted agent like HER2 positive breast cancer or hormone positive CA breast. All these can, even if in the stage 4, you can live for next 3 to 5 years easily with these targeted agents. And EGFR mutated CLM, like from the recent this Floran osimertinib trial, it is said that for the median OS, even after 3 years, it is not reached. Then prostate cancer with the hormone treatment, you can have a decent prolongation of the survival. And melanoma with immunotherapy, all these things are newer with the newer addition of drugs and newer targeted agents. Now the thing is going like you are living with cancer even if in the stage 4. Another group of disease in which there is a significant role of chemotherapy, like in Ewing sarcoma, osteosarcoma, Wilms tumor, rhabdomyosarcoma, all these, there will be a major treatment like surgery and radiation also, but there is a role for this chemotherapy. Now we have proven some benefits. Definite benefits have been proven proven in these things, like CA breast, CA colon and rectum, NSCLC, CA ovary, CA endometrium, CA stomach. In all these things, we have proven there is benefit for adjuvant chemotherapy in increasing the cure percentage by adding chemotherapy to the definitive surgery. By at least for 10 to 15% in almost all the cases. Then the neoadjuvant role has been proven in CA breast, CA rectum and anal canal, osteosarcoma, CA bladder, NSCLC, CA ovary, all these group of disease, we have proven the neoadjuvant role also. So the chemotherapy has proven its role in curative setting, metastatic setting, adjuvant setting, neoadjuvant setting, all those things. So where this chemotherapy doesn't have much role, like in sarcomas, in most of the sarcomas, chemotherapy doesn't have much role. The surgery is the definitive treatment. In hepatocellular carcinoma, chemotherapy doesn't have much role, but small molecules have some roles. In renal cell carcinoma also, chemotherapy doesn't have much role, but small molecules like TKAs have some definite roles, like that. So coming to the single agent versus combination chemotherapy, what is this? Single agent chemotherapy, you are giving only one agent with a maximum effort, but there will be response, but it will be short-lived. That's what we are seeing in the single agent chemotherapy. It is usually given in a metastatic setting only. If you are treating in a curative setting, we prefer for multi-agent chemotherapy. Combination chemotherapy developed by choosing toxicity, mechanism of action, resistance of mechanism answer. What do you mean by that? If you combine two drugs, the mechanism of action will be different, the toxicity will be different, the resistant mechanism will be different, and the kinetics will also should be different. Because You cannot combine two drugs which have same mechanism, same toxicity. If you combine with the two drugs that is having the same bone marrow suppression, there will be significant bone marrow suppression. If you combine one with a bone marrow suppression and the other having a peripheral neuropathy, then you can give maximum dose for the two drugs. This will give maximum cell kill, acceptable toxicity, and provide multiple interactions with the cells and in a heterogeneous population. So, example of this combination chemotherapy well known is RCHOP, ABVD, MOBP, CMF, FOLFOX, all these things. Then optimal duration of this chemotherapy. How many cycles? Usually in adjuvant settings, it will be 6 cycles. This is what we have learned from that local theory. Why is this 6 cycles? 6 cycles means 6 log reduction. 6 log reduction is from 10 raised to, you are detecting a cancer at 10 raised to 9. You are doing a surgery so that it will become subclinical. So it is less than 10 raised to 9 cells remaining. So if you give 6 cycles, 1 log reduction, 10 raised to 6, from 10 raised to 9, it is coming 10 raised to 3. So our immunity will kill the remaining cancer cells. That's why we are giving this 6 adjuvant cycles. Okay. Then coming to the cumulative toxicity versus benefit. If in a metastatic setting, you can give chemotherapy till there is progression, if there is no toxicity. Then how to improve your chemotherapy efficacy? That's by dose intensity. You can give maximum dose. That will give what happens if you give maximum dose, increasing dose, the intracellular concentration of the drug also will increase. That will having maximum cell death. Dose density means you are shortening the time interval between 2 cycles, so that before the regrowth of the cell occurs, you are giving the next chemotherapy. So again, one hit again. Then sequential scheduling means one group of like you maybe heard that in CA breast AC followed by T. That means anthracycline will be given followed by taxanes. That will give 2 different mechanism, 2 different action. Will have maximum effect. Then concurrent versus sequential. In concurrent chemo radiation versus sequential chemo radiation. Then how you calculate the chemotherapy dose? It's basically based on the body surface area. It's an equation to calculate the body surface area, height into weight divided by 3, root of height into weight divided by 3600. And another formula is called the Calvert formula, that is used to calculate the dose of carboplatin, target AUC into GFR plus 25. Then coming to the chemotherapeutic agents classification. It's just an academic interest. Like there are several classifications in which we go by the chemical structures. It's called divided into alkylating agents. Alkylating agents is again divided into nitrogen mustards, ethyleneamine, alkaline sulfonate, nitrosurias, triazines, all those things. So the commonly heard drugs are like cyclophosphamide comes in alkylating agent, ifosfamide comes in alkylating agent, then bendamustine, then temozolomide, procarbazine, all these comes in alkylating agent. Another thing is platinating, platinum agents, cisplatin, carboplatin, oxaliplatin. These alkylating agent platinum are having the same mechanism of action, that is producing alkylating agent will alkylate the DNA, platinum will platinate the DNA, both will produce DNA intercalation and stopping of the DNA replication. Then comes the antimetabolites. Folate antagonist, that's methotrexate, pemetrexate, purine antagonist, that's XMD6TG, azathioprine, fludarabine, then pyrimidine antagonist like 5-fluorouracil, cytarabine. These are the group of antimetabolites. Then comes the antitubulins, that is mitotic spindle poisons. In those comes Vinga alkaloids, that is vincristine, vinblastine, vindaciine. Then comes the taxanes, paclitaxel, docetaxel, eribulin. All this comes under antitubulins. These are having different mechanisms of action. Vinga alkaloids will inhibit the polymerization. Taxanes will inhibit the depolymerization of tubules. Then comes the topoisomerase 2 inhibitors. That's etoposide and mitrazosanrole. what this do is the DNA unwinding. Then comes the anthracyclines. It is also having multiple mechanisms of actions like DNA intercalation, topoisomerase inhibition, all those things, and this thing also, reactive oxygen species also. Then comes the topoisomerase 1 inhibitor, that is called the camtothecin analogs, that is irinotecan and topotecan. Then comes the antibiotics. In antibiotics, usually bleomycin, mitomycin, anthracycline, all this comes. Then miscellaneous like arsenic, hydroxyurea, and L-asparagines. These are the classification of the drugs. Then coming to the toxicities that we are commonly encounter. Each drug is having specific toxicity. That it will be very vast, and it is very difficult to tell in single slide or 2-3 slides. So I just name the toxicity. So first and foremost that we are having concern is the bone marrow suppression. Why this is important? Because that dose limiting, the limiting toxicity is by sir, is my time over?
No, please continue.
Sir, 5 more minutes.
Yeah.
The bone marrow suppression is the dose limiting toxicity. That means you cannot stretch the bone marrow function to a particular level, so that you may be having problems with the decrease in the lineages like anemia, neutropenia, and all. So other things are nausea, vomiting, alopecia, mucositis, diarrhea, peripheral neuropathy, renal and hepatic impairment, gonadal suppression, teratogenesis, and second cancers, bladder toxicity, hearing problems, immunosuppression, cardiotoxicity, neurotoxicity, pulmonary toxicity, fatigue and weakness, muscle pain, skin and nail changes, and DVTs. So some important things that we have to remember is this cardiotoxicity of these anthracyclines, hearing problems and renal problems by cisplatin, peripheral neuropathy by paclitaxel and this oxaliplatin, and bone marrow suppression by almost all the drugs like the anthracyclines and docetaxel. Alopecia, it is very particular in all the taxanes. Mucositis by 5-fluorouracil, diarrhea by 5-fluorouracil. All these things are important when it comes to treatment regimens. Then one important thing is febrile neutropenia. Why it is important? Because the most of the treatment-related toxicity, treatment-related mortality in a chemotherapy occurs because of this febrile neutropenia. That is fever that is more than 101 degree Fahrenheit or 100.4 more than 1 hour with an absolute neutrophil count less than 1,500. It should be considered as a medical emergency. And it should be treated like you are treating at the coronary arteries, patient with a heart attack. Because the first dose of antibiotic has to be given as early as possible. What we advise is you start the antibiotic first, then come to the hospital. We are giving some one strip of antibiotic with the patient, and once you feel that you are in a period of neutropenia and you started having fever, you take the antibiotic and come to the hospital. That's what the importance of starting the antibiotic as early as possible. This is more important once you are treating a hematological malignancy and with a very intense chemotherapy. But in other case, you can treat it with certain good results. What are the things? It can happen due to the disease or due to the treatment. And once you detect it is a febrile neutropenia, there will be some risk scoring mechanism. And this is a multinational association for supportive care cancer risk index. If you have to score by this risk, and you have to assess the risk so that you can treat the patient in an OPD basis or an IP basis. And timely identification is very important, because most of the people only will have first you have to suspect a neutropenia. that by knowing the chemotherapy schedule and when will be the neutropenia will be maximum, and that you have to learn by time. And once you suspect a neutropenia, then you have to see whether the patient is having any features of inflammation like any redness, any mucositis, any tachycardia, any respiratory symptom, any GI symptom. All those things will be the initial symptoms of a sepsis that you have to pick by thinking that the patient will be having a neutropenia. And low risk needs only treatment by OPD basis, but high risk has to be admitted in the hospital. You should have started with some broad spectrum antibiotics with an anti-pseudomonal coverage and consider it as an emergency. And don't hesitate to escalate antibiotics if hypotension or unexplained tachycardia. You have to give meropenem or carbapenem, anything to treat the patient. Then coming to another, the final things like targeted therapy. It's another mode of treatment. Like you are having a target to which the drugs will be acting. By these target, these mechanism, the cancer is going, and you are blocking that pathway. That's what happening in the targeted therapy. It's like the cellular molecular level mechanism. So types of drugs, there will be small molecule or monoclonal antibodies. Example like BCR-ABL, anti-BCR-ABL like imatinib, anti-HER2, anti-EGFR, anti-ALK-ROS1, all these things. There is also having some adverse effects, and finally comes the immunotherapy. Like this also having some different mechanism of action like immune check-in inhibitors, T-cell therapy, monoclonal antibodies, vaccines, and immune system modulators. By any of these mechanisms, your immunotherapy can act. But we commonly use these immune check inhibitors. Like that's what so many researchers are going in this area. And another thing coming is the T-cell transfer therapy, that is called the CAR-T therapy. These two things are also coming very promising. So by this, it will be, we have covered almost the basics of chemotherapy and drugs.
Thank you, Dr. Suneesh. Now, the session is open for discussion. I think I saw one question in the chat regarding proton therapy. Yeah, can any of you answer this regarding proton therapy, indication, side effect, and advantages over radiotherapy?
Okay, sir. Proton therapy. See, as I mentioned, there are two types of therapeutic radiation which we use. One is electromagnetic one, which is a common X-ray or regular radiation. The other one is particulate radiotherapy. Particulate means it's particles, not just electromagnetic waves. So in this particulate radiotherapy, there are commonly the two things which we use commonly. One is electrons therapy, and then comes this proton therapy, which has recently come, but not very common proton therapy. The thing is, proton therapy and the electron therapy, they are a bit specific to the tumor. They act at the tumor site, and especially electron therapy is usually used to treat surface cancers, especially skin cancers or such lesions, or chest wall recurrence, such lesions. But when you say about proton therapy, it's like almost like regular radiation therapy or the like the IMRT, like that. But the thing is, here we use particles, and these particles go and hit the tumor, but the energy release stops there at the level of tumor. In case of regular radiation therapy or the linear accelerator, whatever which we use commonly, the energy passes through the tumor and it exits through the body. So the lot of normal tissues also get into the radiation field. But in case of proton therapy, the particle go and it hit the tumor and energy gets released there, and the energy just stops there, just like that. So the side effects are slightly lower in cases of proton therapy, but the problem is we don't have the machines are not much common here. The common ones which we use here are linear accelerators, which commonly produce electrons and the regular X-rays or the photons. Whereas in case you need protons, you have to install special machines for that. There are cyclotrons machines are there to generate this form of protons. And usually it's a bit costly also, since it's coming up. The advantage is, since the normal tissue is spared, there are lesser side effects, both acute and long-term side effects are less compared to the regular radiation. That is the advantage with the proton therapy. Usually it can be used to treat those organs where the critical structures are at risk, especially in the head and neck area, where the eyes or the optic nerves to be spared, or the hippocampus to be spared, or the spinal cord tumors, where you need to treat the spinal cord tumor, but you have to spare this normal spinal cord. Such areas, its proton therapy is said to be useful. I don't have experience with that. And other thing which I know, that it is more costly. And yeah, the effects are like when you compare IMRT with the proton therapy, results are almost the same. But slightly maybe the side effect profile is better with the proton therapy. That's what I have to share. Thank you.
So I think the next question is to Dr. Suneesh regarding the side effect between immunotherapy and conventional chemotherapy.
Yes. So the conventional chemotherapy is the side effects of the conventional chemotherapy is because of the cellular damage that is produced by the chemotherapeutic agent. That is the normal tissue, normal dividing tissue also is getting killed by the chemotherapeutic agent. But what happens in this immunotherapy? That is, our own immune system is activated against the tumor cells. Actually, what happens is the tumor cells are escaped from our own immune system. Our immune system cannot find the cancer cell. That's what the cancer cell is tricky. So it is smart, so that it is escaping our tumor immune system. What we do by this immune therapy is we are exposing the tumor to the immune system. We are giving some antibodies. We are making a linkage, a bridge between our immune T cells with the tumor cells. That's what the immunotherapy, that's how it is acting. But what happens once you give the immunotherapies, there is a group of disease called autoimmune disorders. We maybe had that there is an energy or central energy, so that our own cells are also escaped from the immune system by this kind of mechanism. Our own cells are not attacked by the immune system by familiarizing or putting some epitopes of the antigens hidden by the cells. But once you give the immunotherapy, this can also get activated, so that it may have a multitude of autoimmune disorders can have with the anti-tumor effect. That's the difference between the chemotherapy and the immunotherapy. But usually this can be controlled with some immunosuppressant agents, and we can rescue the patients almost every time. But in chemotherapy, what happens is the majority of the problems are due to the cell kill by the chemo drugs. And that's the major difference.
So another question is again regarding chemotherapy and immunotherapy. With patients having low Karnofsky performance scale score or ECOG score, how much it is valid to proceed with the chemo or immunotherapy, and whom to give chemo or immunotherapy?
Very pertinent question, because there we have to see 2-3 things. One thing is what produced the this low ECOG or KPS status. If the patient is pre-diagnostic to the this particular problem, if he is having a deterioration of the health, if due to the advancing age or some other organ damage, is he getting worse and worse over a time? And on the top of that, this new cancer came. Or if the problem is only due to the cancer and he was very active just before diagnosing the problem, and if you think that the if you treat the cancer, then he may get improved. That makes the decision very proper. So, that needs he has to undergo a multidisciplinary evaluation by all the specialists, and this comes once you try to treat the advanced patients with advanced stage. So in that case, you have to see the geriatric score by any of the scoring measures, and you should be confident in getting some proper assessment, and then only you decide on going for a treatment. Like sometimes we have seen patients who are symptomatic with the treatment. Once you started the treatment, getting improved with the with symptoms and getting the ECOG status, all those will be getting improved. Like it's particularly seen in myeloma patients. Like the patients will be bedridden because of the spinal problems. But once you start treating him, he may improve dramatically. Like things what's happening in the lymphoma also. So the decision to treat a very poor ECOG status is not only based on the ECOG status per se, but you have to consider what is the disease, what was the pre-diagnostic performance score, whether the patient is symptomatic only due to the disease per se, or is he getting frail because of the advancing age. All these things you have to consider. And if you think that it is a chemo-responsive tumor, and you can get some benefit by even if in a low-dose chemotherapy, then you can surely give some treatment and you will see the result. And if you feel that if it is if you can treat with immunotherapy, there are some markers you can do beforehand, like PD-L1 score, tumor mutational burden status. This may direct you that this kind of patient will be cured by immunotherapy. Then you can try for that. So I think the answer is considering all these things, you can decide on treatment for an ECOG 3 or very low ECOG patient.
Suneesh, when would you take a call, stop the treatment and allow for palliative care?
What, sir?
When would you take a call on a patient to say that, all these things are not working and now palliative care is the most appropriate way to do it?
Okay, so consider a situation. If a patient comes after multiple lines of chemotherapy and the patient goes on progressing, and you think that any further chemotherapy may not be possible for him considering the toxicity of the treatment, then you should discuss with the patient first. What will be your goal further? Whether your chemotherapy may deteriorate your general condition, and you will be having multiple hospital visits. You have to undergo so much of supportive care, so that mostly he will be hospitalized for the time being. In that case, you have to consider putting the patient in a palliative care, so that you think that you reach a point so that you cannot help him with the further chemotherapy, but you are adding to the morbidity of the patient. Then you have to consider shifting the patient to palliative care. But if that patient comes to you for the first time, and you feel that it is not a chemo curable condition, like I told you, some of the sarcomas. If you think that it's a hepatocellular carcinoma metastasis to all the areas with the underlying liver disease, and the childhood score is B or C, and general condition is also poor, then also you will be thinking that the patient will be best for a supportive care only, not for any disease directed therapy. So it differs for each patient. But if you think that an 80-year-old patient, he was reasonably okay before the diagnosis of a lymphoma, and you think that it is a DLBCL, and the patient is symptomatic, like patient is having pleural effusion and symptomatic only due to the pleural effusion and the general weakness, and you think that you can treat him initially with a steroid, and the patient may improve by 1 or 2 doses of steroid or a low dose cyclophosphamide or a vincristine. Then he shows, if he shows some response, then you can go on with some more cycles of the treatment. But if there is no response and the patient goes on deteriorating, then also you should turn the direction to a palliative care. So all the decision of taking a palliative care, only palliative care means you should have consider all these points, because you should consider a curative opportunity or some benefit for the patient with some of the treatment modalities, and you feel that further any disease-directed treatment will not add on to the benefit of the patient and will increase the morbidity of the patient, then only you will decide this patient is for palliative care only. I think you...
Yes, I got it. Yeah, because most of the time what we see is, these people come with very advanced stage 3 and 4, where even the oncologists, when they see for the first time, they are not able to do much for the patient. So, so they have to take a call very fast, whether it's advisable to go for active treatment or involve palliative care, So we see those kind of
sometimes it's a combined decision, sir. Actually, some of the patient will not be interested in chemotherapy. Sometimes the family may not be keen for any chemotherapy. Sometimes even from the considering disease per se, we cannot offer much kind of a treatment also. So all these things have to be taken into consideration, I think.
Thank you, sir.
Sir, can I stress one thing? Like the thing which Dr. Suneesh mentioned in his presentation, there are few cancers, even if presented in a stage 4 or advanced stage, they're worth treating. Like CA prostate with bone mets, because most of the CA prostate get present with bone mets, or lymphoma sometimes, carcinoma thyroid, like especially the papillary and the follicular types. There are some things which responds well. So you give a chance for such patients, that will be better. And recently, nowadays, we have newer modalities like the embolization and all. So recently we had a patient, elderly patient, but a huge tumor on the chest wall, bleeding. So radiation was tried, but that was not feasible. So this embolization, that worked very well, and patient was symptom-free, the bleeding stopped. So so you can, in case the patient can afford and they're willing, you can go. You have options nowadays, more and more options, even though it's advanced stage.
Okay.
Sir, and I think
Yeah.
discussion regarding the advanced care planning and referral to palliative care in the stage of advanced disease is much valid in chemo or radiotherapy. When we are planning for chemo or radiotherapy, as soon as the palliative care referral or advanced care planning discussion is done, it is better for the patient also, I think so, sir.
Yes, nowadays what is happening is, from the first consultation itself, we most of the multi-specialty team includes the palliative care physician also, so that the patient also feels that they are all the symptomatic benefit also is taken care of along with the definitive treatment. And once you stop this definitive treatment for the disease, the palliative care team will continue with the patient, so that the maximum comfort till the end of life is given. So nowadays, what the thing is, the early discussion with the palliative, early consultation with the palliative care physician is the what we are doing in most of the cases.
Okay, Dr. Punita has asked a question. Dr. Suneesh can answer that. Is there any empirical immunotherapy or need some expensive test to see if patient with particular tumor will respond or not.
Actually, the problem is this immunotherapy. Usually, in our experience, what we have seen is immunotherapy have showed maximum benefit when the performance score is very good. If you give immunotherapy to a very sick patient, we are not getting that much of a result, because the mechanism of action is also different for the immunotherapy. The patient immune system has to be strong enough to get a thing. And the markers for immunotherapy also, it's not a, we cannot rely on, because what we are doing before giving the immunotherapy, we are checking the PD-L1 status. PD-L1 status, in some patients, even if you get a more than 50% of PD-L1 status, but we are not getting that much of a result. There are some things that that makes the decision of immunotherapy very tricky. So nowadays, what we do is give immunotherapy in the first or second line maximum. In the later lines, not to introduce immunotherapy. The test that we are using is still the PD-L1 status. Then we are just assessing the tumor lymphocytes, TILs, tumor interstitial lymphocytes. Then the other tests like tumor mutational burden, and then MSI status. All those things can be tested to know whether the patient will be benefited by a immunotherapy. But the decision to treat in a later stage, like beyond second or third line, that you cannot tell. I think the results will be not that much promising, in at least in our experience.
I think even if the medical oncologist or radiation oncologist want to do the early integration of palliative care, the patients are not ready to go with the consideration by the medical oncologist. As I'm working in the palliative care center and in the Apollo Cancer Center, Chennai, many of the times I've seen patients will ask all the possible options like immunotherapy, radiotherapy, proton therapy, and after that also they won't consider with the medical oncologist. And then after the patient after they realize that the patient is not going to live, like then only they will consider for the palliative care. This is the one true struggle even the medical oncologists are having.
Yes, sir. Actually, I was working previously in Lakeshore. What happens is all the new patients will be seen by the palliative care physician also, and he will give a briefing like what all things will be given, like what the medical oncologist will do and what he will do. Like he will give a prognosis. He will give a plan for his symptomatic era and all. That's what we usually follow in that time. But now, actually, I am working as a single physician, so I am doing all these things, and palliative care also done by me only.
Any more questions?
So basically, we don't get to interact with the radiation oncologists and even medical oncologists so frequently like this. So it was a very good opportunity for us to learn many things. Such multidisciplinary things should happen frequently.
Okay, now I think in most cancer hospitals there is a tumor board which consists of radiation oncologists, surgical oncologists, medical oncologists, as well as a palliative care physician. So I think it's slowly coming up in many hospitals, but it will take time to get interact with the oncologist. But you know, the younger generation of oncologists are more, they are very approachable at least, so that you can discuss things with them. So I think this was a very useful session because it covered the basics which we actually don't know. So Dr. Manu talked about many things in radiation oncology, what advanced technique and the older techniques and how radiation acts, etc. And Dr. Suneesh talked about the mechanism and the cell mass that is 10 raised to 9 and how it becomes 10 raised to 12. So those, I think most of us for it would be a newer concept. So thank you both for introducing the new concept and making us aware the importance of knowing the basics. So thank you, Dr. Manu, as well as Dr. Suneesh for this wonderful class. And thank you everybody for your active participation. It's over to Sri.
Thank you, Dr. Manu. Thank you, Dr. Suneesh. It has been, I believe, a wonderful session for all our fellows out there listening to the new knowledge about the radiation oncology and medical oncology. So without much delay, since we have correctly, am I audible?
Yes.
Yes.
Okay. Because the screen got stuck, so I thought maybe I lost the network. So thank you everyone for joining and making this session as interactive as each every previous sessions. Please don't forget to leave your valuable feedbacks for our speakers because we'll be sharing it with them. A synopsis of your feedbacks we will definitely be sharing with our speakers. So please do remember to leave that as well. And this is Sripriya along with Dr. Manu, Dr. Suneesh and Dr. Sunil Kumar signing off from the Pallium India's presentation desk. See you in the next session. Till then, everyone take care. Keep spreading happiness. Bye-bye.
Bye.
Thank you. Bye.
Thank you. Bye.